Hi all, welcome back to Emergency Medicine Lecture Series. Pain is one of the most important complaint that patients present to ED. One of the most important qualifications of an emergency physician to identify the pain correctly and treat pain, both to produce patient comfort and to facilitate the examination in a correct manner without any hindrances. In the current lecture, I'm going to deal about how to manage acute pain, what are the pharmacological options available, what are the non-pharmacological options available, and what are the conditions where each of those pharmacological classes of drugs can be useful. I'm Dr. S. Prakash Babu, Associate Professor of Department of Emergency Medicine. So patients presenting to ED, the main complaint in almost 70 to 80% of patients is pain. Oligoanalgesia, the undertreatment of pain, persists despite the advancements in understanding pain management. The vulnerable groups for oligoanalgesia include elderly who have cognitive differences and they feel pain differently because of their experiences and their mental condition impairments. Very young people who cannot express their pain or suffering because of pain, and it's very common to neglect the pain management part in very young children. Remember, even young children, infants also feel pain. They need to be given comfort. People with cognitive impairment who cannot complain of pain or who over complain of pain are usually the most neglected population for oligoanalgesia, and they should be taken care of. Pain management is also negatively influenced by the ongoing prescription of opioid misuse, where the doctor thinks that patient is already been on opioid use, so his pain may not be reduced with other medications, which is not true. Specific measures to treat pain should occur in addition to and at the same time as the treatment of the underlying illness or injury. Pain control should be individualized. There is no hard and fast rule what type of medication, what methods to reduce the pain you use in each patient. It should be individualized to a given patient and you choose the modality of pain management. Medications that act on specific sites that initiate the pain signal, a mechanistic approach are preferred to agents which reduce the pain. So coming to the pathophysiology of pain, how pain is produced. All of you know pain is a physiologic response to any obnoxious stimulus. That is the sensory response. The suffering due to pain is modified by complex interaction of cognitive, behavioral, and socio-cultural dimensions. Individual pain experience mainly depends on the current and the past medical history the patient has undergone, the physical, emotional maturity of the particular given patient, cognitive state, what they mean pain. Each person will have different meaning for pain. The family attitudes and belief, culture and environment will all influence the reaction to pain, that is suffering due to pain. Emotions can modify pain either negatively or positively. Fear and anxiety may accentuate pain. Pain can be suppressed completely if an essential task must be performed or if there is an acute concern about a loved one. Pain cannot be assessed objectively, it's always a subjective assessment, and only the patient can tell how much pain the patient is enduring. Self-reporting is considered the gold standard for quantifying the severity of patient's pain. Coming to how the pain is produced, how it is transmitted, the two types of receptors for pain. One is nociceptors and the other is mechanoceptors. The nociceptors receive the exact sensation of pain, whereas the mechanoceptors receive pressure signals which can lead to tissue damage that can cause pain. Nociception is a stimulus that can damage the tissues. So there are primary afferent neurons which are transmitted to the dorsal root ganglion and they relate to the dorsal horns in the spinal cord. There is a crossover of fibers between pain and touch, and then the fibers will travel in the spinothalamic tract. The secondary afferent neurons transmit impulses from dorsal horn to the thalamus, which is the relaying center. From thalamus, the neurons going to cortex, which modify the pain sensation, the emotional part of pain sensation, there is suffering. The descending pathways, which come back and relay the dorsal root ganglion, modify the pain signals that are perceived. Pain receptors and initiators. Somatic pain is usually received by nociceptors, which are C fibers and A delta fibers. They carry signals through the dorsal horn. Neurons in the dorsal horn integrate and modulate input from multiple peripheral nerves. Spinal cord sends impulses to the hypothalamus, thalamic nuclei, limbic system, and the reticular activating system. Identification and localization of pain, cognitive interpretation of pain, triggering and emotional and physiologic reactions also occur at the central sites, especially in the cortex. So how are you going to evaluate pain? Pain is part of the essential vital sign obtainment and it needs to be documented during triage and also during the initial assessment. Evaluate pain using Socrates. The previous video about taking history in emergency patient, I told what is Socrates. The patient's objective reporting of pain is the basis for pain assessment and treatment. There is a weak correlation between non-verbal signs such as tachycardia, tachypnea, and changes in patient expression and movements and patient's reporting of the pain. Do not depend on non-verbal cues completely. It's always the patient's subjective reporting of pain which forms the basis that how much pain the patient is having and how you need to approach the pain. Pain scales. The primary purpose of pain scales is to quantitate pain severity, guide the selection and administration of an analgesic agent, reassess the pain response to determine the need for repeated dosing or alternative analgesics that need to be chosen. Essential in pain management research, enabling reproducible comparisons of any interventions that have been done. The goal of getting a pain scale is to control pain to the level the patient desires. So this is the universal pain assessment tool where you have a numeric rating scale in which the patient is asked to grade his pain from 0 to 10, where 0 is no pain and 10 is the worst pain possible. Next, you have adjunctive rating scale where the patient says the pain as in adjectives like no pain, mild pain, moderate pain, severe pain, very severe pain, and worst possible pain. And then there is Wong-Baker's facial grimace scale, which is mostly an objective scale, wherein you look at the patient's face for different expressions like smiling to comfortable, which becomes gradually uncomfortable, and finally the patient starts crying where it is a severe pain. And then there is visual analog scale in which there is a graded colored bar in which the patient will place a point about his severity of pain that is taken as from no pain to worst imaginable pain. This is how you evaluate the pain assessment. Then there is visual analog scale. Pain intensity is measured in millimeters from no pain, and a difference of 13 millimeters is the minimum clinically significant change noticeable by patients. Average decrease of 30 millimeters appears to be minimum acceptable change for pain control. Numeric rating scale can be used in patients with visual, speech, or manual dexterity difficulties by using upheld fingers, but it is not as discriminating as visual analog scale. A 5-point global scale, a decrease in 1 point is a large change. Scales with more choices allow monitoring for small changes in pain. So 5-point global scale may not be useful in the emergency department. Verbal quantitative scale most commonly used, and it's very easy to administer. Pain scales in special populations, how they perform. Visual, hearing, motor, and cognitive impairments can be barriers to effective pain assessment. Trauma patients and those with acute intoxication do not perform as well on pain scales. Elderly often report pain differently. Women are more likely to express pain and actively seek treatment for pain. When there are language difficulties, class cultural differences, visual analog scale is the preferred pain assessment tool. So after assessing the pain, you need to start managing pain. For acute pain management, is mostly done with pharmacological therapy. Non-pharmacological alternatives may not be useful in the ED setting, but once the patient has been admitted to either ICU or to the observation unit, you can start non-pharmacological treatment. The key to effective pharmacologic pain management in the ED is selection of an agent appropriate for the intensity of the pain, time to onset of analgesic activity, ease of administration, safety, and efficacy of the drug. Acute pain is usually accompanied by anxiety and feeling of loss of control. So you need to manage them. You can use one of the benzodiazepines along with your pain medications. Management of the suffering component of acute pain may be best managed by restoring emotional control and providing information about what exactly is happening, how much damage the patient has undergone, and a proper development of a rapport between patient and the caregiver. If verbal reassurance combined with analgesic does not suffice, you can go for an anxiolytic like a simple benzodiazepine like lodazepam or midazolam. In the earlier days, a tiered approach to analgesia has been used, wherein you start with an agent of low potency regardless of the severity of the pain or intensity of the pain. You assess the response after a clinically relevant period of time and then sequentially changes to agents of higher potency. The problem with this approach is it unnecessarily subjects patients to prolonged suffering. A patient with more severity of pain may not respond to a low potency drug. If appropriate, it is appropriate to select agents on the basis of initial pain intensity rather than using a tied approach in the emergency medicine department, especially to give comfort to the patients and facilitate examination and the investigations. Agents of choice that are available to you when you are managing a pain include the first and foremost class of drugs are non-steroidal anti-inflammatory drugs. They can be used to mild to moderate pain, severe pain originating from smooth muscle spasm, and systemic opioids, severe nociceptive pain. Acute neuropathic pain can be dealt with antidepressants and anticonvulsants. Severe pain in the extremities can be amenable to nerve blocks, which gives an advantage of less toxicity and more prolonged pain control. For fractures, you can choose a hematoma block. So these are the options that are available to you in the ED. First, let us focus on the opioid analgesics. They are the cornerstone for management of severe acute pain. Opioid refers to agents that are structurally related to the natural alkaloids, whereas opioid describes any compound with pharmacologic activity similar to an opiate. Opioids should be titrated to effect after the initial dose. Variation in pain reduction is related to age, initial pain severity, and previous or chronic exposure to opioids. Oral opioids, less commonly used in the ED, but they're commonly used in the OP clinics, usually come in combination with NSAIDs. Codeine, which is a poor analgesic, needs to be converted to active metabolites like morphine and hydromorphone or hydrocodone, causes more nausea, vomiting, and dysphoria. Then you have tramadol, which inhibits mu receptors and prevents reuptake of serotonin and norepinephrine. The analgesic potency of tramadol varies according to the patient's cytochrome 450 activity. There are more side effects compared to other easily available IV opioids like dizziness, nausea, constipation, and headache. It is a less preferred agent in acute conditions. Then you have the systemic steroids, which can be used in the emergency department. They need to be titrated to the level of or intensity of the pain and keeping in mind the complications that they can produce. One of the most commonly used drug is morphine, which is a natural alkaloid phenanthrene derivative. Adult dose is 2 to 6 milligrams IV or 10 milligrams IM or subcutaneous or 10 to 20 milligrams per oral as an IR tablet. The onset of action of morphine starts within 1 to 2 minutes when you give it as IV, 10 to 15 minutes for IM or subcutaneous, and 30 minutes for oral tablet. Achieves a peak effect within 5 minutes when you given by IV, within 30 minutes when given by IM, and it lasts for 2 hours IV route, 4 hours IM or subcutaneous rate, and 5 hours as tablet. The main problem is with morphine is it has the potency to release histamine, which produces transient hypotension, nausea, emesis. Neither requires a routine adjunctive treatment. But the therapeutic index of morphine is very, very low. You need to be very careful when you are giving morphine. Most studies have shown that morphine has increased the morbidity and mortality in patients, especially those with severe illness. So alternatives to morphine like fentanyl, hydromorphone is a semisynthetic phenanthrene, 0.5 to 2 milligrams IV, 1 to 2 milligrams IM. Onset within 5 to 15 minutes IV, 10 to 20 minutes is the peak effect. Duration lasts for up to 4 hours, but it has a propensity to produce more euphoria. So a better choice when it comes to opioids is fentanyl, which is a synthetic phenylpiperidine group of drug. 50 to 100 micrograms IV is the dose. 100 micrograms nasal spray and in one nostril. 100 micrograms buccal mucosa tablet is also available. Onset immediate after IV dose. Peak effect is within 30 to 60 minutes. Duration lasts for 2 hours. Terminal half-life 6 hours. On repeated dosing, it can accumulate and increase the duration of effect. Less cardiovascular depression compared to morphine. High doses greater than 5 micrograms per kg IV can cause chest wall rigidity. But for analgesic purpose, you don't need greater than 5 micrograms per kg. 1 to 2 micrograms per kg can produce excellent pain relief in patients. So let's have a look at the equipotent doses of opioids. Morphine 10 milligrams is equal to hydromorphine of 1.5 milligrams, which is equal to fentanyl of 0.2 milligrams, 0.1 milligrams, meperidine of 75 milligrams, and codeine of 120 milligrams. So the preferred agent in emergency seems to be fentanyl. When it comes to opioid pain management, adjunctive medications to reduce the side effects like vomiting, nausea, ondansetron 4 to 8 milligrams IV or per oral can be used. Prochlorperazine 5 to 10 milligrams IV, IM or per oral. Promethazine 25 to 50 milligrams IV or IM. Metoclopramide 5 to 10 milligrams IV, IM or per oral can be used to reduce the side effects. Opioid agonist antagonists which are used to reduce the respiratory depression that is produced by the usual opioids. Buprenorphine or 0.3 milligrams IV or IM every 6 hours or 75 micrograms of buccal film every 12 hours, 1 milligram IV can be used. Pharmacokinetics onset is very rapid. Elimination half-life is 20 to 44 hours, so longer duration of action. Morphine equivalence is 10. Butorphanol, which is commonly used in pain due to pancreatitis, 1 milligram IV or 2 milligrams IM every 3 to 4 minutes. 1 milligram nasal spray every 3 to 4 hours can be given. Onset is less than 1 minute. Elimination half-life is up to 6 hours. Dejocin 0.1 milligrams per kg IV every 4 hours. Nalbuphine 10 milligrams IV, IM or subcutaneous every 3 to 6 hours. Pentagocin 30 milligrams IV, IM or subcutaneous can be used. Coming to the non-opioid analgesics, most commonly used drug is acetaminophen or paracetamol. Adult dosage is 325 to 1000 milligrams per oral every 4 to 6 hours. It can be given as 1 gram IV infusion every 6 hours or 15 milligrams per kg IV every 6 hours. Problem with acetaminophen is liver dysfunction necrosis is very infrequent at the normal doses. The next choice is aspirin, again 325 to 650 milligrams per oral every 4 hours, 300 to 600 milligrams per oral every 4 to 6 hours. It can cause GI irritation, mucosal bleeding, platelet dysfunction, tinnitus, CNS toxicity, and metabolic acidosis. Normally used for as an antiplatelet agent, not as an analgesic. Ibuprofen 400 to 8 milligrams per oral or 400 to 800 milligrams IV every 6 hours. Naproxen 250 to 500 milligrams per oral every 8 to 12 hours. Indomethacin 25 to 50 milligrams per oral every 8 hours. Ketorolac in the dose of 15 milligrams IV or IM every 6 hours or 10 milligrams per oral every 4 to 6 hours can be used. Other drugs, other non-opioid drugs that can be used are for pain relief include ketamine 0.1 to 0.3 milligrams per kg, maximum of 30 milligrams IV or 10 to 15 minutes, can be repeated in 1 to 15 minutes up to 0.5 milligrams per kg, or can follow an IV infusion of 0.1 to 2 milligrams per kg per hour. No renal and hepatic adjustments are needed. Administer slowly to reduce dystonic reactions, laryngospasm, and mental status changes. Adverse effects are uncommon with single dose. Dizziness, agitation, and hallucinations are possible with higher doses. Lidocaine, especially used in patients with irritable colic. Fixed dose of 50 to 150 milligrams IV. Weight-based 1 to 2 milligrams per kg IV can be used. No consistent benefit in migraine, renal colic, radicular back pain. Adverse effects noted in 9% of patients. It's not an FDA approved administration for acute pain management. If the patient is having a neuropathic pain, acute exacerbation of neuropathic pain and is presenting to emergency department, you can go for either antidepressants or antipsychotics. Amitriptyline, nortriptyline, used for chronic pain. Initial dose is 25 to 50 milligrams per oral once in the evening. It can be titrated to increase every 2 to 3 weeks. 10 to 50 milligrams per oral is the typical effective dosage. Carbamazepine, specially indicated for trigeminal neuralgia, 100 milligrams per oral twice a day, increase 100 to 200 milligrams per day. Oxcarbazepine, again used for trigeminal neuralgia, 300 milligrams per oral daily can be used. Duloxetine, in patients with diabetic neuropathic pain, 30 milligrams per oral once a day. Gabapentin in patients with neuropathic pain and post-herpetic neuralgia, 300 milligrams per oral on day 1, followed by 300 milligrams per oral twice a day on day 2, 300 milligrams per oral 3 times a day on day 3 can be used. Pregabalin, again used for diabetic pain, neuropathic pain, post-herpetic neuralgia, 50 milligrams per oral 3 times a day, 75 milligrams per oral twice a day can be used. Coming to the topical agents of acute pain relief, diclofenac comes as 1% gel or 1.3% topical patch. Apply using a dosing cart, 4 grams for knees, ankles and feet and 2 grams for elbows, wrists and hands. Lightly rub until absorbed. Use up to 4 times a day. Maximum total daily dose is 32 milligrams patch. Apply to intact skin at most painful site twice a day. Ibuprofen 5% gel. Squeeze 50 to 125 milligrams or 4 to 10 centimeters of the gel from the tube and lightly rub into the affected area until absorbed. Apply up to 4 times a day. Ketoprofen comes as 2.5% gel. Squeeze 2 to 4 grams of the gel from the tube and lightly rub into the affected area until absorbed. Apply 2 to 4 times per day. Lidocaine comes as 5% gel or 5% topical patch. Capsaicin comes as 0.025% cream, 0.075% cream, 0.1% gel and 8% patch. Methyl salicylate comes as 10% patch. So that's about the pharmacological agents that can be used for acute pain management. The caveats in pain management: safe and effective use of opioids is facilitated by choosing an appropriate initial dose and titrating to the desired level by incremental doses. Acute pain management for the elderly can be a challenge. Opioid naive elderly patients are more sensitive to analgesic effects of opioid drugs. They are more sensitive to sedation, respiratory depression, cognitive and neuropsychiatric dysfunction due to opioids. Initial IV opioid doses in the elderly are typically half those used in the younger adults. In patients with renal failure, hydromorphone and fentanyl are preferred opioids. Non-pharmacologic modalities: application of heat or cold, immobilization and limb elevation, cognitive behavioral techniques like reassurance, explanation, reframing, relaxation, breathing exercises, music, psychoprophylaxis, biofeedback, hypnosis, and distraction are all available but not useful in the ED setting. And physical modalities like electrical nerve modalities, acupuncture are again for chronic pain management. Thank you. We aren't after the pain medications, we are after treatment that will reduce the pain. This is a big difference. Thank you once again. Don't forget to share and subscribe the videos for wider dissemination.